morning, everyone, and thanks for coming. I'm Dr. Brian Ballios. I'm here at the University of Toronto and the University Health Network in Toronto, Canada, and coming to you live. And thanks, everyone, for taking the time to join. CyberSight and Orbis have invited me to come and present on the clinical examination and management of inherited retinal diseases. And we'll try to go over some learning points this morning to help with the interpretation and the approach to some of these very challenging conditions in ophthalmology. Some disclosures to start off. I have some funding, and I am also have been a clinical trial investigator and sub-investigator on several different trials related to cell and gene therapy, and continue to consult and advise some of these companies. I'll start off with a simple review of basic genetics. We all know that in humans, there are 46 chromosomes in the somatic cell, 44 autosomes, and 2 sex chromosomes, XY in male and XX in female. And the haploid gametes have 23 chromosomes. And most genes are inherited in Mendelian inheritance patterns. That is, genes are passed on, and misspellings in genes can manifest particularly and in inherited retinal diseases in the classic Mendelian patterns: autosomal dominant, autosomal recessive, X-linked recessive or dominant. And the job of the ocular geneticist and the IRD specialist is really to understand both the genotype and the phenotype of disease as it informs the patient and the families that these conditions affect. It's important to remember as we go through this talk that there is a large amount of intrinsic heterogeneity and genetic variability between individuals. There's estimated to be over 4.5 million differences in coding between any given individual that we might sequence and the reference human sequences that have been developed over the last 20 years since the mapping of the human genome in 2001. A few more important facts to remember that can sometimes be intimidating when we think about genetics. There's over 20,000 genes in the human genome. And we think there's also, in addition, a large number of what we call pseudogenes, or genes that we're not sure whether they have a biologic function yet, and some of the functions are being uncovered. They may have a function in producing proteins, and they may have a function in regulating how other genes are expressed. Our understanding of inherited retinal and optic nerve diseases and genetic diseases of the eye has grown immensely since the 1990s, and then of course with the mapping of the human genome in the early 2000s. And in the late 80s, early 90s, we only knew a handful of genes that we thought were responsible for genetic retinal disease. And even this graph is not quite up to date. I say here over 316 genes that we know are important for causing inherited retinal diseases and inherited genetic ophthalmic disease. But right now, most gene panels are over 320 genes on that panel. I think if anyone here has a background in ophthalmology, as probably most of you do, you know about rods and cones. You know that rods comprise the vast majority of light-sensitive photoreceptors in the retina, over 120 to 130 million rods per human retina, and are important for our navigational vision at night. And they do not function in daylight or bright light conditions like I have in my office or on a bright sunny day. Cones are a minority of light-sensitive photoreceptors, but they are very, very important. They give us our visual acuity, they give us our color vision, and our navigational vision in daylight. So let's jump right into some of the common genetic retinal conditions that can occur when there are misspellings and mutations in any of these genes that we know are important for vision and the retina. Retinitis pigmentosa is the prototypical, the archetype of a genetic retinal disease, and that's because it's probably the most prevalent clinical entity that you would encounter in the clinic for a patient who is presenting with a genetic retinal condition. Electrophysiologically, as we used to define, before we knew about genetics, we used to define these conditions based on how they appeared on the ERG, the electroretinogram. And so electrophysiologically, RP is a rod cone dystrophy. That means it primarily shows, at least early in disease, primarily dysfunction in the rod system, followed by progressive dysfunction in the cone system. Genetically, it can be inherited in all of the classic Mendelian fashions: autosomal dominant, autosomal recessive, X-linked. In most cases are simplex or sporadic cases where the patient may be the only person in the family affected with no known family history. And we think that most of these cases are likely autosomal recessive cases that have not yet been genetically defined. Misspellings can occur in a variety of genes that affect the photoreceptors and the retinal pigment epithelium that helps to support photoreceptor homeostasis, both metabolic and structural homeostasis. These misspellings can be in genes that are associated with retinal metabolism, with the structure of the photoreceptors, with ciliary structure, function, and extension, or even with transcription factors that define the different cell types of the retina. So clinically, what does retinitis pigmentosa look like? Here I give an example of a 9-year-old who presents with complaint of difficulty seeing at night. When they try to play with their friends after the sun goes down, they have to come in early because they're not comfortable playing outside. They have difficulty if they have to get up in the night and find their way to the bathroom, for example. They need to turn on all the lights in the room. When they go into a dark theater, for example, or into a dark room, it takes them longer than their friends to adapt to those dark situations. They haven't had any problems with their visual acuity. They have very strong vision, 20/20 vision. And when we look at their retina in the color photo in the top left, has a fairly bland and normal appearance. The optic nerve has a good color, and the vessels have good integrity. The macula and the fovea have a normal pigmentation. When we do an autofluorescence image, shown in the top right, we can see some abnormality. We see some preserved foveal hypoautofluorescence, but a bright ring of perifoveal hyperautofluorescence surrounding the fovea. And when we look at an OCT of this macula and a line scan through the center of the fovea, we see good preservation of foveal banding and outer retinal structure, but in the periphery of the macula, we see thinning of that outer nuclear layer and loss of the differentiation of that outer retinal banding. Right now, the patient has normal visual fields. I give an example of a Goldman visual field showing that it's normal. This can be some of the earliest picture of retinitis pigmentosa. You do not need to have the pigment that you might classically see in those photographs in your textbooks of retinitis pigmentosa. But structurally, we can already identify changes in thinning of the peripheral photoreceptors. And an ERG really tells the tale. When we look at the scotopic or dim flash rod response, we see compared to normals that this response is severely attenuated. In fact, we cannot see any robust response when you look at the trace in the bottom left. And when you look at the cone flicker and the 30 hertz flicker, you can see that already, if you compare the amplitudes to normal and to our patient with RP, the amplitude of the cone response is diminished. And so cones are already being affected early in the condition, even if they are preserved centrally and the patient has good central visual acuity. Here's the patient's mother. And here we're starting to see some of the changes. She's 40 years old now, and we see pigmented changes in the periphery. Not very pigmented, not the classic dense bone spicular pigmentation you see in a textbook, but some light bone spicular pigmentation and noted peripheral retinal atrophy. We see, when we can think about her imaging and autofluorescence compared to the child's, that there is a ring of hyperautofluorescence in the perifovea that's tighter to the fovea, representing the edge of this progressing ring or zone of atrophy. And her OCT shows a smaller island of preserved central structure. And certainly on the visual field, we see constriction to the dim isopter, the 1,4E, even with preservation of the 5,4E. And of course, as the patient gets older and as the visual field progresses in a centripetal fashion towards the center, as the visual field narrows and the atrophy progresses into the macula, we see that pigmentation becoming more dense. And this is the typical picture you think of in your textbook of retinitis pigmentosa: dense, hyperpigmented, bone spicular pigmentation with disc pallor and attenuated vessels. And a little bit of media artifact there from a posterior subcapsular cataract, which is often associated with RP. The autofluorescence shows peripheral hypoautofluorescence. Again, that media artifact in the center projected from the posterior subcapsular cataract, but some preserved hyperautofluorescence in the macula. And of course, this patient has quite constricted visual fields down to barely 20 degrees in the 5-4E. And so even though the visual acuity may still be preserved at this point in the disease, the visual field is severely limited. And in most countries, with patients with visual fields below 20 degrees, they'd be classified as legally blind. So this patient would be significantly disabled in their daily visual functioning and would need significant assistance in orientation and mobility. If we do microperimetry, we overlay that with the autofluorescence and we overlay that with the fundus image, then we can see that yes, there is a preserved island of sensitivity in the central macula, but outside of that central macula, in the peripheral macula and in the periphery, the patient does not have any significant sensitivity on psychophysical testing. So that's typical RP, but typical RP are not always the most challenging cases to diagnose. So let's talk about some variability. RP can show significant regional variability within the retina. I show an example at the top of something called sector RP, where it's only one sector of the retina that's affected. In this case, a patient having a near peripheral hemifield affected we see a band of atrophy along the inferior near periphery extending into the nasal periphery, with the corollary, the scotoma shown on the Goldman visual field in the superior hemifield. Patients can also have regional variability of pericentral patterns with a near peripheral or peripheral macular ring of atrophy. And we see the corresponding ring scotoma on the Goldman visual field. It turns out that these two patients are from the same family and they have the same genetic misspelling causing their condition. And so even within families, patients with the same underlying genetic cause can show significant heterogeneity in the types of regional variability they have in their RP. We can also have X-linked RP, and it can be difficult to identify patients, especially female carriers with X-linked RP, because they don't show the same atrophic changes as the male members of the family do who carry the condition. But in female carriers of X-linked RP associated with genes like RPGR, we see this almost reflective sheen on the surface of the retina when we look inside with the fundoscope. And these patients on autofluorescence have this streaked pattern of radially oriented hyper-autofluorescent bands, which really raise the specter, the possibility this female patient is a carrier of an X-linked disorder. Sometimes females can be much more affected with X-linked RP than we might otherwise predict, and can show significant asymmetry in the pattern of their findings, even central macular atrophy and peripheral atrophy. And so these patients may be not as symptomatic as the male members of their family, but they may also complain of difficulty with navigational vision, side vision, night vision, and for some cases, even central vision. And so we have to be very aware of the broad spectrum of presentation. And finally, as I mentioned before, autosomal recessive retinitis pigmentosa is really the most frequent pattern we see. And so more often than not, patients present as isolated cases with the only member of their family that they know of being themselves who are affected. And there's a variable prognosis associated with a large variety of genes that cause autosomal recessive non-syndromic retinitis pigmentosa. I list a small subset of them. It really looks like an alphabet soup. And I bolded down in the bottom right USH2A because that's the most common gene associated with autosomal recessive retinitis pigmentosa. It also happens to be the gene most commonly associated with something called Usher syndrome type 2, which we'll get to in a second. But misspellings in this gene are also responsible for the vast majority of autosomal recessive RP. RP is not the only kind of inherited retinal disease that we see in the clinic. Here we see an example of a patient with choroideremia, a young boy, age 7, who has good foveal and parafoveal pigmentation, but a modeled hyperpigmented change in their mid and far periphery, showing clumps of hyperpigmented lesions at the level of the RPE. This patient is probably complaining of similar things to the young child with RP, complaining of difficulty with dark adaptation, difficulty with nighttime vision, but probably having quite excellently well preserved visual fields at this young age 7. Unfortunately, as is true in RP, is also true in choroideremia. As this condition progresses and we look at some autofluorescence images, by the patient's early to mid-20s, we see on the autofluorescence image only areas of preserved central macular RPE and outer retina. The periphery, what you're seeing there is the reflection from the bare sclera. You're seeing the choroidal vessels that have atrophied, and you're seeing some of the vortex veins that are all visible on the surface of the fundus, but the RPE and underlying choroid have undergone atrophy. So really, this patient has a central island only, and by their early to mid-30s, that island is shrinking. Remarkably, these patients can present with very well preserved central visual acuity, but significantly constricted fields. The patient's mother was also examined, and even though she's asymptomatic with normal visual fields and function, she shows quite a dramatic appearance to her fundus. And we see areas of, again, hyperpigmentation with clumps of pigment at the level of the RPE, with a normal looking nerve and blood vessels. The autofluorescence really shows these changes even more clearly. But importantly, when we look in the periphery of both of these images, we see some radially oriented bands or cords of hypo autofluorescent changes that again suggest to us perhaps this is a female carrier or a lionized version of this genetic disorder. She has normal visual fields to all isopters that were tested and also had a normal electroretinogram. What about this case? A 34-year-old male at the top whose fundus looks very much like the choroideremia examples I gave you. But then we look at the bottom and we see a 34-year-old female, a different patient, not from the same family, that comes to the clinic that has a picture that also looks something like choroideremia. But we know that choroideremia is an X-linked disorder. And so we think to ourselves, this could not be choroideremia because it's males who are affected in this fashion. And in the 34-year-old female, we see areas of scalloped and nummular areas of chorioretinal atrophy in the mid to far periphery, with preservation of RPE pigmentation and outer retinal health in the center. We think to ourselves, what might be going on here? This looks something like choroideremia, but doesn't follow the familial inheritance pattern. And that's where phenocopies become very important. We have to remember that sometimes disorders of the retina that are caused by different genes and different mutations can look and appear very similar, both in how they present on fundus examination and how they function and how the patients present with their visual complaints. And so this is an example in that 34-year-old female of gyrate atrophy, which is an autosomal recessive condition caused by a mutation in a very important enzyme for how RPE and photoreceptors function, and it can show a similar pattern of peripheral atrophy that progresses centrally in these patients. And so we should think about phenocopies, or things that look similar but are caused by different genetic causes. Well, I've been speaking a lot about non-syndromic retinal dystrophies, and I think it's worth talking a little bit about syndromic generalized retinopathies, because these genetic disorders do not always occur in isolation in the eye. And we need to think about the fact that sometimes they affect multiple body systems. And so we think about some of the classic examples being ciliopathies like Bardet-Biedl syndrome, a patient who may present with developmental delay, with polydactyly, sometimes with problems with kidney function. Joubert syndrome and Senior-Loken syndrome and Alström syndrome are all other examples of ciliopathies that may overlap in their spectrum of clinical findings. Mitochondrial disorders that you've probably learned about if you were doing studies in ophthalmology or clinical ophthalmology, the Kearns-Sayre syndrome, where patients can present with a pigmentary retinopathy, but also with problems in cardiac conduction, deficits in cardiac function. The Usher syndromes, of course, the classic syndromic retinitis pigmentosa that presents with RP and early onset hearing loss. Depending on the type, it could be stationary hearing loss with early onset sensory neural hearing loss, or progressive. Paroxysmal disorders, ataxia, the NCLs and A-beta lipoproteinemia. There's a wide variety of inherited genetic conditions that can present with something that looks like RP, but also with other syndromic features. So here's some clinical clues, for example, Usher syndrome, as I mentioned, hearing loss in RP, Bardet-Biedl syndrome, I went over. The patients usually are at the higher end of weight, polydactyly, hypogonadism, learning disability, or developmental delay. Adult Refsum disease. These patients have a metabolic disorder and have retinitis pigmentosa, peripheral neuropathy, and hearing loss, with also an associated loss of smell and taste. And so teasing apart these clinical features is a reason why it often takes some time to sit with the patient, understand their history, and ask a good review of systems and past medical history. Let's turn to Leber congenital amaurosis. These are patients who have little to no sensitivity to light from birth. They have a variable presentation. There's a picture of Theodor von Leber, and their ERG is abolished or profoundly abnormal from early in their life. These are primarily inherited in autosomal recessive fashion. Of course, has a differential diagnosis. When you see a young person, an infant or a child with difficulty from vision that seems to be congenital or early onset, to think about these other disorders that may present: achromatopsia, bloom chrome monochromatism, congenital stationary night blindness. The ERG can distinguish it, but that can be very challenging in children, even with an exam under anesthesia and an ERG. But an ERG and functional testing is very important, particularly in these children, to tease it apart, because the fundus changes may not look that dramatic early on. Well, here's a young patient who presented to my clinic. This is she was a 12-year-old girl, and she'd been given a diagnosis of congenital stationary night blindness around age 7. And she was complaining at that time of difficulty with nighttime vision. And her parents had always noted that she much preferred to do all activities with bright lights, and tried to avoid situations where she was in the dark, either with her friends or when she was around the home. Her visual acuity was 20/60 in both eyes, and you can see her visual field to the 5/4E and 1/4E isopters are actually quite well preserved, with some areas of deficits on static perimetry overlaid on top of the Goldman fields. Her fundus doesn't show pigmentary changes, but we get the impression that there's at least some sheen to the retina in the periphery and maybe some atrophy. The fundus autofluorescence shows significantly attenuated global fundus autofluorescence, globally hypoautofluorescent in both eyes. The OCT didn't seem that dramatic. Good preservation of foveal structure, some blurring of the ellipsoid zone and external limiting membrane, some thinning in the peripheral macula, but actually quite well preserved. The ERG results were dramatic. She had severe attenuation of both the rod, combined rod and cone system across the board. And so this brings me to talk about some of the retinal dystrophies associated with misspellings in the gene RPE65. These patients have a variety of symptoms and signs which can help us differentiate them in the clinic. And this is a particularly important clinical entity to identify in your patients. And I'll get to why that is in a second. So some of the symptoms that she checked off: she had nyctalopia, she had some photophobia, but it wasn't a dominant symptom. She had prolonged dark adaptation when she moved into a dark room. Her parents did note when she was an infant, she would rub her eyes and have light-seeking behavior, as I mentioned. The signs, the clinical signs: a flat and completely extinguished ERG is classic in RPE65 associated retinal dystrophies. Reduced global autofluorescence. This is an enzyme that recycles vitamin A, and when it's deficient, there is reduced global autofluorescence. Diminished visual acuity, but not 2200, 20/60 in both eyes, with structure function dissociation, meaning good preservation of viable photoreceptor cells in the fovea with diminished function. Genetic testing revealed 2 misspellings, biallelic misspellings in the RPE65 gene, one inherited from mom and one inherited from her father. Segregation was confirmed by testing the parents, and that's important because there is a gene therapy for this disorder that has been approved and is increasingly available across the world. And having this proof of the genetics, in addition to showing viable retinal cells, is the necessary criteria for Luxturna qualification. And so she would be a wonderful candidate for Luxturna based on just a simple clinical examination and verifying the phenotype and the genotype. And gene therapy in RPE65 is a success story. This slide goes over in principle how the gene therapy works. The Luxturna or Veretagene naparvovec is a adeno-associated virus carrying a properly spelled copy of the RP65 gene. It's injected in a subretinal injection underneath the macula and central retina in a vitrectomy surgery. The virus infects the cells in the outer retina and produces a properly spelled copy of the RP65 enzyme, which reestablishes the normal cycling of vitamin A in the outer retina. And these patients show dramatic improvements in multiluminance mobility testing, essentially a visual optical course at dim levels of illumination where they would have had significant difficulty navigating and avoiding obstacles before treatment. There are other disorders that show similar features to RPE65 associated retinal dystrophy and are the target of ongoing gene therapy trials. I give an example of another gene that causes Leber congenital amaurosis, CEP290 associated retinal dystrophy. Fairly bland looking fundus, some peripheral atrophy and mild pigment changes, and an OCT that shows very good preservation of central macular structure, even though this patient has 2200 vision, which may surprise you, but goes to show that these patients that show structure function dissociation may be excellent candidates for gene therapy to restore the function of those photoreceptors. Moving on to cone rod dystrophies, these are clinically variable disorders. They show atrophy in the central macula where the cones are the predominant cell that's affected. They may show hyperpigmentation, no pigmentary changes, or hypopigmentation, and so they can be very difficult to distinguish on examination alone. They show a variable extent of central and peripheral involvement. And in order to make these diagnoses, electrophysiology becomes your friend. Very important to be able to do an ERG, a full field ERG on these patients to demonstrate reduced cone and rod responses and put that together with your clinical picture and what you're seeing. Here's an example of PRPH2, peripherin-associated cone rod dystrophy. The color fundus photo and examination can be difficult to interpret. And so whenever possible, obtaining an autofluorescence can definitely be your friend in making these diagnoses. And when we compare the two images, the changes pop out right away on the fundus autofluorescence. Large areas of nummular, in some places confluent, RPE atrophy, definitively dark autofluorescence in the central macula, the peripheral macula, and the near periphery, some granular hypoautofluorescent changes in the mid periphery, and some quite well preserved autofluorescence, not totally normal, but well preserved in the far retinal periphery. Again, gives us the impression on examination that this is a disorder affecting the central retina, primarily the cone photoreceptors, with sparing of the far peripheral retina where rods predominate. Sometimes the fundus can look quite bland. And so this is a male patient with an X-linked cone dystrophy caused by misspellings in the RPGR gene. Put that in your mind that the RPGR gene was mentioned before when I talked about X-linked retinitis pigmentosa. And we're going to come to this point later, that sometimes depending on where the misspelling is in the gene, it can cause very different clinical phenotypes. In this case, the mutation in RPGR causes an X-linked cone dystrophy in this young male. And the fundus looks, again, quite bland, some interretinal sheen, no hyperpigmented spots or bone spicules. The fundus autofluorescence, however, highlights the fact that there are changes within the macula. Especially in that left macula, there is an area in the superior parafovea of some hypoautofluorescence showing some early atrophy. And of course, the most remarkable feature, as you saw right away, was the quite well-defined hyperautofluorescent ring in the parafovea of both eyes. The ERG in both of those cases showed significant cone dysfunction with preservation of rod electrophysiologic signals. Macular dystrophies are the final type I'd like to discuss, and then a few special cases. Stargardt disease is the prototypical macular dystrophy characterized by early central vision loss, usually in the juvenile age range, teenagers and young adults in their early 20s. The classic clinical description is a beaten metal or beaten bronze appearance to the fovea. That's not always true in patients with Stargardt disease. The yellow-white deep subretinal flecks, again, that's the classic description, can look very different, and we'll show some examples. Chorioretinal atrophy is what happens as time progresses, but initially can be a rather non-specific fundus appearance. Stargardt disease has variable expressivity. It is autosomal recessive and related to the ABCA4 gene, which is one of the largest genes important for vision. It's on chromosome 1, and it's important for moving retinol into and out of the outer segments of the photoreceptors. It is expressed in rods and cones. Here's a color fundus photo of the right eye showing the classic yellow hypopigmented flecks in the parafovea, the peripheral macula of this patient with still quite well preserved foveal pigmentation. But here's another example. Here's a patient with a spectrum of ABCA4 associated dystrophy that we call fundus flavimaculatus. This is an older patient, and they have widespread flecks across the posterior pole. These flecks don't always show up so well on the Optos scanning laser ophthalmoscope, but on the autofluorescence, it's quite dramatic. And you can see, of course, an area of confluent, definitively dark autofluorescence in the central macula. You see the granular hypoautofluorescence in the peripheral macula and near periphery, and these flecks show up as punctate discrete points of hyper and hypoautofluorescence in the mid to far periphery. This patient electrophysiologically presents with cone rod dystrophy. They have significant attenuation of cone responses, some preserved rod responses, but the rod responses are not completely normal. And this really fits with the fact that we can see in this patient, the entire retina is affected. So sometimes ABCA4 can present with ABCA4 associated macular dystrophy, and sometimes with a more generalized retinopathy. As time goes on, these areas of retinal atrophy can expand beyond the macula into the near periphery. And these patients can be some of the most significantly visually disabled patients that we have, with large central field scotomas, some preservation of side vision, but significant difficulty, of course, as you would expect with central and reading vision, but also with navigational vision because the side retina is involved. So in classic Stargardt disease, Stargardt macular dystrophy, in order to be a macular dystrophy, the full field flash ERG really should be normal. And that's true in the majority of cases. And we can reassure those patients with a normal full field flash ERG in most cases that their side vision will remain strong as their life continues, even if their central vision becomes more difficult. But of course, in those patients that are defined as a cone rod dystrophy or a generalized retinopathy, we can't be as confident that they won't change over time. And so it's very important to get electrophysiology, especially a full field ERG in Stargardt disease. There is a differential diagnosis, though, of course, as there is in everything. We can think of mitochondrial disorders, other cone rod dystrophies, cone dystrophies, acquired conditions, and I'll show you some examples. Here's an example of a patient with, on the left, case 1, a electrophysiologic macular dystrophy with normal function of the peripheral retina, but with significant atrophic changes in the perifovea and the parafovea. And this patient has other family members that show a broad spectrum of presentations. In case 2, we see those changes within the central macula and the near periphery. And in case 3, we see those changes not just in the macula, but also in the near to mid periphery. And this patient and their family members had a misspelling in a mitochondrial gene called MTTL1, which causes a mitochondrial maculopathy. It also happens to be the most common cause of maternally inherited diabetes and deafness. And so these patients had a history of maternally inherited difficulty with early onset hearing loss and a history of diabetes. The clinical phenotype can also overlap with the MELAS syndrome, mitochondrial encephalopathy, lactic acidosis, and stroke. And patient number 2 had a history of stroke-like episodes when they were younger. And so all these patients need to be thought of as not just flecks within the posterior pole, but maybe some changes that might reflect a syndromic macular or generalized retinal dystrophy. As I mentioned, acquired conditions can also mimic inherited retinal dystrophies. And so we shouldn't forget some important publications that have come out in recent years showing that pentosan polysulfate, a medication often used for bladder dysfunction, can show up with central retinal and macular toxicity that shows up with patterns that look very, very similar to mitochondrial dystrophies or pattern macular dystrophies. Let's talk about Best disease for a second. And here I'm showing a patient that we have with a best one associated vitelliform macular dystrophy. We can see quite clearly in the right eye in the central macula, a vitelliform lesion, focal, well circumscribed in the fovea. The left eye has a normal looking fovea, and sometimes these patients can confuse us because they don't always obey the rules of symmetry that we think of when we think of bilateral symmetry in inherited retinal disease. In fact, the autofluorescence shows this vitelliform material in this patient, this hyperautofluorescent vitelliform material in the right eye, but normal autofluorescence in the macula of the left eye. The OCT shows the vitelliform material in the right eye and normal lamination of the left eye, although if you were quite critical, you might think that there was some thickening of the interdigitation zone in the fovea of the left eye. We watch this patient over time, and the vitelliform material in Best disease often, as time goes on, is resorbed, leaving a pseudo cleft of fluid underneath the central macula, which can often go on to atrophy, and patients have decreased central vision over time. In the left eye, we're starting to see the appearance of vitelliform material. And so both eyes can progress along their own timeline. And even if at presentation there appears to be stark asymmetry, as time goes on, the other eye can begin to be involved. Of course, there's a wide variety in which Best trophinopathies can present. Here's an example of multifocal vitelliform lesions throughout the macula and the near periphery in other patients. But what characterizes all of these Best trophinopathies, or diseases associated with misspellings in the BEST1 gene, is the absence of a light rise and a low Arden ratio on the electrooculogram shown on the right. The full field ERG in these patients is often normal or could be mildly subnormal, but the EOG is always abnormal. It defines this as a channelopathy and dysfunction of the RPE. Let's talk about one last clinical condition, and that's X-linked retinoschisis. It's an X-linked disorder, and males are affected and females are completely unaffected. It's due to misspellings in the RS1 gene. It encodes a very important structural protein called retinoschisin. It shows complete penetrance, and but can show intra and interfamilial expression variability between males that are affected. The visual acuity can be normal in young individuals, but they start to complain of difficulty with their central vision, usually in early school age. And that vision can be fairly stable until the 4th or 5th decade when the macula begins to continue to atrophy. But it has a very important ERG pattern called an electronegative flash ERG, and I'll show you an example of this. And this can help you with making this diagnosis. These patients on fundus examination, and shown well here on infrared imaging, show a spoke wheel pattern of schitic cavities within their central retina and within their macula. These schitic cavities can be present centrally. They can also be present peripherally. And because they can also be present peripherally, these patients are often at risk of retinal detachment, retinal tears, even with what we might think of as fairly mild trauma. This retina is quite fragile as this important structural protein is mutated. The OCT shows us these schisis cavities within the fovea, the peripheral macula, and I show the example on the left of the full field flash ERG, the combined rod and cone response showing an electronegative response. The first downward deflection you see in that ERG is the A wave, showing a normal photosensitive A wave signal from photoreceptors. The B wave, which should normally rise up above the baseline, is severely attenuated. And so you see that the upward deflection never rises back above the level at 0 time. It never goes up high again. And that tells us there's dysfunction in the signaling between the photoreceptors and the bipolar cells. And that's reflected structurally in the schitic cavities that characterize this disorder. I'm going to end my talk by putting aside the clinical phenotypes for a second and just talk a little bit about the evolution of nomenclature in inherited retinal disease. So I've shown you a lot of different clinical entities, and it may become confusing after a while to be able to associate a gene with a clinical entity. And there's a couple of reasons to start to change over our IRD nomenclature from a phenotypic classification like retinitis pigmentosa, Stargardt disease, to a molecular classification where we focus on the gene. Number one, it's because the new gene therapies that are coming are really focused on treating the misspellings, mutations, and structural variants in genes, not always focused on the specific phenotypes. And then secondly, tagging the second identifier phenotype after the gene, it really lets us be more precise in what is the underlying molecular etiology of these conditions. And this is why it can be very confusing. Here's I love this image from a paper by Berger and colleagues in 2010. I really like this because it shows us the classic clinical phenotypes as large circles, and then the genes that are associated with those clinical phenotypes. Now, some genes are associated very specifically with the clinical phenotype, but there are several others. For example, take CRX, which is in the orange intersection on this diagram. CRX lies at the intersection of a phenotype that can look like Leber's congenital amaurosis, a later onset cone-rod dystrophy, retinitis pigmentosa, and in fact, some deletions in CRX can even cause some macular dystrophies. And so this is an example of a gene where different misspellings or structural variations, deletions, duplications within the same gene can lead to different clinical expression of phenotypes. And that's one reason why I think it's important to define our conditions based on the genotype. So here's what I mean. On the left, phenotypic classifications, we would talk about rod cone dystrophies, or we call it retinitis pigmentosa, or we talk about achromatopsia based on the clinical presentation. What does the retina look like? Its structure? How does it function? On the right is the argument for how to reassociate these under the gene heading. So for example, instead of talking about Stargardt disease, we would call Stargardt disease, classic Stargardt disease, an ABCA4 associated macular dystrophy. And that would allow us then to differentiate between ABCA4 associated macular dystrophies and cone-rod dystrophies. We're not losing the clinical information in the phenotypic classification because that's important information for us as clinicians to get a rapid sense in our mind of what is this patient's major complaints going to be when they come to us in the clinic and they're looking for our help. We understand the problems that a patient with a macular dystrophy has that's different than a rod cone or a cone rod dystrophy, but it does define it in a molecular way so we can understand how is this condition going to change over time, how will it be inherited within families, and how is it going to interface with the new therapies that are coming. So genetic testing, if you haven't got the point yet, is very, very important for defining genetic retinal disease. Diagnosis, it gives us a firm molecular etiology. Prognosis, it allows us to segregate and confidently interpret variants within families and counsel other family members, including the patients themselves and their own plans for reproductive counseling when they're thinking about growing their own families. And it identifies actionable variants like that RPE65 gene that we can use for a gene therapy. Genetic testing is becoming much cheaper since the advent of next generation sequencing in 2007. It was progressing along a logarithmic curve after the drafting of the human genome, but disruptive technologies have allowed the cost of sequencing a single human genome to drop down to now just below $1,000, well within the range of commercial sequencing, well within the range of what might be accessible to our patients around the world. Remember, when this started, the mapping of the human genome, it cost over $100 million US to map the human genome. A final plug for the importance of an IRD clinic. I'll take the last 2 minutes to do that, and then we'll leave time for questions. Some tips about taking a history in the IRD clinic. I think it's really important that you sit with these patients for some time and really understand their story over time from when they were very young. Even for patients who presented my adult inherited retinal disease clinic at age 55, at age 60, at age 65, I always go back and ask them, how old were you when you first noticed changes in your vision? And if the patient is having difficulty describing the exact onset of time, I'll take them right back to when they were children and say, when you were 5, 6, 7 years old, were you happy with your vision? Did you have any problems? And then I'll take them forward another 10 years. I'll say, when you were a teenager, when you were in high school, when you were in finishing school, what did you notice? Were you happy? Could you read the board? Could you do your homework? Did you have to sit at the front of the room and not at the back of the room? Did your parents have concerns? These changes over time are important for defining the condition. Remember, you may be seeing the patient at a later stage of their condition, and it may be difficult to differentiate whether you've got a cone rod dystrophy, a rod cone dystrophy, is this retinitis pigmentosa. Listen to what their earliest changes were in their vision. It can often tell you what kind of condition you're dealing with. Ask them about dark and light adaptation, night vision, their reading vision, of course. How's their reading speed? Are there gaps in words? Do they lose their place on the page? Do they have to adjust the light to read? Their color vision, their side vision, and their sensitivity to light. Do they prefer are they more comfortable with their vision on bright sunny days or on overcast days? Or are they somebody who really, when they work, like to sit in a dark room with a spot of light? This is an example of how you might structure a referral to an inherited retinal disease clinic, a referral sheet. I like to have the physicians and optometrists and other healthcare providers who send me patients, as much as possible, try to fill this in, even though they might not be able to do it perfectly. What clinical diagnosis do they think they're dealing with? What are the principal symptoms in those categories I described? Central vision, side vision, night vision. What's the visual acuity, of course? Has genetic testing already been done? Sometimes if genetic testing has been done, it's worth a second look to see how the different variants that were identified or not identified were interpreted. And of course, enclose as much information as you can to help provide a baseline for our evaluation. Of course, the IRD is important medically for diagnosis, for prognosis, for assessing patients' retinal function, but it's important to provide a space for discussion about disease prognosis, to clarify preconceptions, and to talk about inheritance and risk, and also to support family planning, patients in their careers, and their adjustment and coping. Practically, we like to connect our patients with low vision and vision rehabilitation resources for orientation and mobility training, for help with reading vision, telescopic and magnification for patients with macular dystrophies, but really to promote a feeling of independence and usefulness. And I think for these patients, it's important that we're giving them back a sense of control. And patients are born with their genetic retinal conditions. They inherit it from their families, or it comes de novo, but it's in their genes. And many patients feel a lack of control because of that, because it really is within the DNA. And so it's about giving back all sorts of control at different levels, cognitively, behaviorally, decisionally, emotionally, and giving hope to these patients because of the new therapies. Some resources for you you can use when you download the slides, and of course, my contact information here in Canada. And we'll move to poll question number 1 to assess the understanding. There's only 2 questions, so this is number 1. Good, we're seeing the results here, and about 40% of people said more than 250 genes, and that's right. And that list is growing all the time. We think we've discovered most of the major genes, but we're still learning about all of the different genes that are important in inherited retinal disease. Let's go to poll question 2. So there's approved gene therapy for retinal dystrophy caused by which of the following genes? USH2A, RPE65, RPGR, or CEP290, an approved gene therapy. That's great. 56% of respondents say RPE65, and you're right. And that's very important and really important for identifying that particular condition based on the clinical phenotype. Some questions have come in while I've been talking, and I haven't been able to look at them. So I'll start. I'll try to answer as many live as I can. And if we run out of time, I'll do my best to answer some later. So anonymous attendee asks, in your experience, how common is unilateral retinitis pigmentosa? So that is, unilateral retinitis pigmentosa is actually very rare. And it's very important in unilateral retinitis pigmentosa that we rule out other acquired conditions. I think unilateral RP clinically, traditionally, has been a diagnosis of exclusion. It's been a diagnosis where you've excluded other acquired causes. An example of an acquired cause might be an infectious cause like Duzen, diffuse unilateral subacute neuroretinitis, which can cause unilateral diffuse pigmentary changes, and the fundus in the other eye is completely normal. Of course, as we learn more about genetics and we're able to define and get access more readily to genetic testing becomes an important part of working up these rare unilateral disorders. And sometimes we can define these conditions. We're not always able to define the genetic cause of all of these inherited diseases. So it always is back on the clinician to decide whether they're dealing with an inherited retinal dystrophy or an acquired cause. So don't forget about your uveitis and your unilateral uveitis. Don't forget about your acquired infectious causes. Drug toxicities normally present bilaterally, but there is a differential for unilateral changes, previous trauma. You can't forget those other things. So that's important to keep in mind. What is EUA, ERG? That was my short form for examination under anesthesia. Doing an ERG on a young child and having them sit for an electroretinogram can be very, very difficult if they're younger than age 7 or 8, in my experience. Some very well-behaved 6-year-olds can sit for an ERG. But for the little children, sometimes you need to take them to the operating room, put them under anesthesia, and perform the ERG while they're anesthetized to get good quality signals and a diagnosis. Someone gives I think that someone's presenting or asking about a case, female, adult, late 40s, noted to have a small area of retinal pigmentation, not typical bone spicules, mild Goldman loss. Electrophysiologic testing is normal, and the conclusion that this abnormal pigmentation was peculiar to her, difficulty with dark adaptation, no family history. Should she have genetic testing done? I think a lot of it depends. There will be so many cases that we can share in this forum uniquely. I mean, we don't have the kind of rounds forum where we can present images from this case. Discrete areas of pigmentation, here are the sorts of things that I would be thinking about. I would come back to some of the general principles of genetics. Of course, we talked about unilateral retinitis pigmentosa. Most inherited retinal disorders are going to show some degree of symmetry between the eyes bilaterally. Of course, there are exceptions, but most of the cases, as you saw that I showed you, showed that. And so one of the things I'd be looking at to give you a clue towards an inherited retinal disease would be the degree of symmetry between the eyes. Certainly, it's very reassuring that her electrophysiologic tests were normal for this patient, but again, some electrophysiologic tests can be normal in different IRDs. It's very important to examine the family members, particularly the parents or the offspring, if you're suspecting an inherited disorder. I think it's a good plan to monitor this patient closely. Repeat fundus photography and visual fields is important. That's a very good plan. Should she have genetic testing done? Genetic testing is becoming more and more accessible. One thing that's important to know is that when you do genetic testing, you need to have a very strong phenotype in order to interpret whether a genotype is going to be related to the clinical phenotype and how to interpret the pathogenicity of any variants. So I would say that after you've exhausted your other investigations for acquired causes, especially if it's an asymmetric pattern, if you're thinking that there are some features that check the box in IRD, then yes, it would not be unreasonable to proceed to genetic testing. And if you have a colleague who has some expertise in the interpretation of genetic variants, or your local clinical geneticist who can also spend some time with the patient, that can be helpful to interpret the results of that test. Because you're going to be left with some results. You have to figure out whether a misspelling in a gene is actually causing the condition, or whether it represents that intrinsic heterogeneity that I talked about at the beginning. That's a good question. Is there any role in multivitamins to improve bits of vision in RP? So this brings us to vitamins in different types of inherited retinal disease. An example, one that you might be most familiar with, is the use of vitamin A for retinitis pigmentosa. There was a large study done in the early 1990s that looked at many patients with RP and put them on high-dose vitamin A, and other ones where we observed the natural history. And that study suggested that even though there was no difference in how the patients progressed in terms of their visual acuity and some other functional metrics, there was some slowing of the changes in their ERG, that the ERG amplitudes, especially the cone responses, were preserved for longer. But unfortunately, that data has been very difficult to replicate by other groups around the world. And so every practitioner is different in how they recommend supplementing with vitamins like vitamin A and retinitis pigmentosa. Some practitioners absolutely recommend all of their patients do it. Some say the evidence is not strong enough. I think there's some better supplements and vitamins coming, and different types of treatments. And you have to be aware that when you're putting patients on very high dose supplements, sometimes their blood work needs to be monitored, their liver function, their blood tests, and especially in vitamin A, if they're older than age 50, it can interact with their bone health. And so these are not benign treatments to put patients on high-dose multivitamins, but it's a part of a broader discussion, I think. Thank you for your talk. Thank you. Can I confirm what you suggested about the change in classification? Perhaps two different conditions which are caused by the same gene would be treated in the same way. I wonder, what do you think about possible downsides? So I think that that's a very good question around changing from phenotypic to genotypic classification. It does imply that some conditions that are caused by the same genetic underlying genetic cause could actually be treated with the same gene therapy, regardless of what the phenotype may look like specifically. Of course, we're always worried about pigeonholing ourselves, and certainly there are, for some genes, multiple modes of inheritance. For example, in the RPE65 gene, there is one particular misspelling in that gene that can cause a dominant type of inheritance, not the recessive typical pattern, but a dominantly inherited retinal dystrophy. And those patients are not amenable to the genetic therapy. And so there have been examples of patients who've been identified with that misspelling, who've been told by their provider, you have a misspelling in the RPE65 gene, go get treatment. And they arrive to some disappointment when they go to an evaluation center and the specialist says, yeah, you've got a misspelling in the RPE65 gene, but it's not the right kind of misspelling. So certainly there can be downsides to any strategy, but I think it does help us expand our thoughts around the types of patients who may be accessible to treatments in the future. In textbooks, X-linked retinoschisis has been associated with hypermetropia. Can it be associated with myopia and multiple lattice? Yes, absolutely. Absolutely. What we were learning more and more is that some of these clinical correlations don't always correspond perfectly. So another example would be in congenital stationary night blindness. We thought all of these patients had to be myopes or high myopes who had the typical incomplete form of congenital stationary night blindness. And it's just not true. There are good examples of patients who are emetropes or hyperopes for all of these conditions. So you really shouldn't pin yourself down to one form. There's the what's been put in textbooks, and then there's what you encounter in real clinical practice. So always be skeptical. They had a patient with typical spoke wheel retinoschisis, multiple foveal lattices, myopic retina. If you do an ERG and you see an electronegative pattern and you have some firm objective electrophysiologic clue to go forward, I think this is a patient that you would consider genetic testing on. Is there any age limit for gene therapy in IRD? Not currently. So for the RPE65 gene therapy, patients have been treated in the 4th, 5th, and even 6th decades of life now. There's examples of that happening. The criteria really depend on a patient with the proper with confirmation of the proper genetic misspelling and evidence of viable photoreceptors on an OCT scan, for example, or on some measure of function like a full field stimulus threshold testing that could tell you that there's something there to rescue with the gene therapy. The photoreceptors are the substrate. As patients get older in these conditions, more and more photoreceptors degenerate and die, and they lose photoreceptors. And so, of course, patients who are older are less likely to have viable photoreceptors. But if you have a patient who does, then we think that in principle, there's no reason that patient couldn't be treated. Remember, our experience with these conditions is still early and evolving. But it's a great question. Unilateral sectoral RP, 40-year-old male with no symptoms but decreased vision. Most cases of unilateral or most cases of sector RP are bilateral sector RP, but there's exceptions to every rule. I think you need to think about not just the structural evidence you have for the sector RP, make sure you've backed that up with ERG and electrophysiologic testing, and ruled out other causes of unilateral retinopathies before you move to a genetic diagnosis. But again, I know that many on this call are probably from centers around the world that are getting better and better access to genetic testing as time goes on. So your ability to confirm or refute a differential is important. But I will say that I think it's very important that we not use genetic testing to rule out diagnoses as part of a panel like we would with a CBC, a complete blood count, or an ANA or an ANCA in uveitis. But we use genetic testing to help us confirm our suspicion of a clinical phenotype. It's not a good screening test, but it's a very good test for confirming your clinical suspicion. Medical therapy and RP neuroprotection. I touched a bit on this with vitamin A therapy, and I touched a bit on this with vitamins. I think is right now, for most of my patients, I recommend sunglasses for comfort on a bright sunny day, avoid smoking, leafy green vegetables, a balanced diet. And there are many more neuroprotective drugs that are being studied right now, like the studies around N-acetylcysteine that are going on that are being run out of Johns Hopkins and other centers across North America that are looking at neuroprotective agents that may be helpful for slowing the progression of disease. And we reached sort of the end of the clock, so I'm sorry for those whose questions I didn't get to. I'm really glad to see so much interest, and I'm always interested from hearing from colleagues around the world and their experience. Canada is a multicultural country. I have patients come from all around the globe, and they find their ways to my clinic, and I'm always interested to hear my experience or the experience of my colleagues. So please do reach out. And I really appreciate the organizers for giving me a chance to talk in this forum. It's quite interesting, and I hope to hear from some of you soon. But anyway, I hope you have a good rest of your day.